Thank you. So everybody made it to the castle last night. Was that quite an event or what?
That's awesome.
But I didn't see a lot of people doing the selfies. I was waiting for, although it got dark. Lorna did the selfies, but. So today, I'm going to talk a little bit about side effects. As a chronic leukemia, we like to say that, you're in it for the long haul, right? So this is a chronic illness until we find therapies that are curative, albeit there's no doubt that there are some patients who have been on treatment or have received the treatment and certainly maybe in remission. Whether those individuals are cured, we hope. So there are certainly some patients really who have done well 20 plus years after some therapy, there's no doubt, even some early patients who have received FCR. So hopefully those individuals are cured, but we tend to shy away from the word cure, because we know that for many individuals the disease comes back, right? So you're living with issues that are chronic in nature, similar to other chronic medical problems, and that's how I couch it with my own patients. I like to say to them, think about high blood pressure, diabetes, heart disease. People may be on medicines for these different issues every day, and you may deal with side effects from those medical problems or those medications that you're on for those medical problems. So this is similar to many individuals who have CLL, that they may, whether they're on medicine or off medicine, you may have chronic issues that you're dealing with lifelong. And so and again, I understand it may vary by region and country. Whether it be your oncologist, hematologist, or your internist or primary care physician, you sort of make lifelong bonds with that person because you are in it for the long haul. So that being said, we'll go forward and we're going to talk a little bit about, I'm going to talk more specifically. I think in general, I just put this up there because when people ask me about symptoms, what do I know, or how am I going to feel if I have CLL? In the most basic sense, most individuals, if they're not requiring therapy, many are asymptomatic. In fact, many people may have gotten diagnosed right without even knowing. They went to their doctor, their blood count was high, they didn't even know. So most are asymptomatic at diagnosis. But as the disease progresses, if your blood counts start to decline, you may have symptoms related to that decline of your good blood counts, right? So if your red cells become low, that's when you hear the word I'm anemic, or anemia is a common term. And people could be anemic for all sorts of reasons. If you lose blood, you're going to be anemic. Okay, so in this sense, we're talking about, the marrow getting crowded out from the leukemia cells, and so your red cell count is low. But you can feel tired and weakness. Think of the red cells that carry oxygen to all your organs. So, it's like gas in the car. So if you're running low on your gas, eventually things start putting, and you're having a hard time. And so that's a sense of anemia. If the platelets are low, you might experience easy bruising or bleeding, okay? And then neutrophils, you won't feel that, but we always are worried about infection in our patients with CLL, and we'll get to that later. Clearly, if you have very bulky disease and big lymph nodes or a big liver or spleen, which is like a big lymph node, you can have compressive issues and things like that. So those are more signs and symptoms of the disease itself. But what about, let's go back. I'm going to have problems with this again today, huh? It's a fussy. Can we go back one, guys? And I will stay away from this. Back two. Another one. Okay, so we're going to talk about treatment-related side effects, your immunity, secondary cancers, and transformation. Okay, fast forward 2 slides. Sorry, guys. I'm going to make you do the work. Okay, so for those, and I'm just going to really briefly talk about some of the key drugs with side effects, and then we'll go into the other issues. So for those who might be on Ibrutinib or BTK inhibitors, I know that you guys have heard a lot about therapy talks yesterday. These are medicines, whether it be Ibrutinib, there's obviously Calibrutinib, there's Zanubrutinib, there's a whole bunch of second-generation BTK inhibitors coming down the pike. So bleeding issues are something we always counsel our patients about. So that, while on therapy, think of it like being on aspirin. That's very simplistic to say, but there are bleeding issues that can occur while somebody is on a BTK inhibitor. So if you're having a surgery procedure, I always counsel my patients, please let me know what kind of surgery are you having, because I may be holding your drug depending upon the severity of the surgery, whether it's minor or major. This is something that you need to talk about with your physician. So if you're on other medications that can also act as a bleeding agent, whether it be an antiplatelet or an anticoagulant agent. It's not that we have no patients who are on a BTK inhibitor who aren't on Coumadin or on an aspirin. That's not the case. I don't want people to think that's not. But the doctor needs to know. Everybody needs to be a champion for your care because it can increase bleeding risks. Next slide. Other common symptoms, and some of you told me about some of your symptoms yesterday. Certainly there's some GI symptoms that can occur. Some of these symptoms, when people first start these agents, are more paramount the first couple of weeks or a couple of months when starting these agents, and some of them dissipate over time. So some, in the beginning, we try to work through some of those earlier symptoms. If somebody's got diarrhea or constipation or arthralgias or joint pains, most tend to get better, but that's not everybody. And so I think it's very important to convey your side effects with your doctor because some of them they may be able to help with or monitor, and some will get better, others may not, and then, then we do consider dose reductions or what to do about your symptoms. Because if the treatment is worse than what you're going through, that's not helpful either, right? We all know that everybody wants to stick to their regimen and be good if it's helping their disease, absolutely. But you have to talk to your doctor because some symptoms can be really, really quality of life debilitating, and that's not fair for anybody. And thankfully, we do have now many agents, and so that's, again, we know that there are access issues, but there are different ways to finesse. And I like to say the treatment of CLL can be very artful. And if you have a good physician, they know how to make that art. So arthralgias, we always talk about the cardiac issues with the BTK inhibitors. So people can get cardiac arrhythmias, the most common being atrial fibrillation, so an irregular heartbeat. And these are common too as we get older. And people who have high blood pressure and may have other coronary risk factors, we have an increased risk too. And so we know that. And so we have to, we balance all these issues together, right? So the incidence of arrhythmias can be about 10 to 15%. And that's something that doesn't go away. As I said, there are some side effects that do go away with time, but high blood pressure and AFib tend to, that can happen late term too with this drug, okay? And again, always discussing your other medications with your physician is important because there may be drug-drug interactions which may increase the levels of your other medicine or the Ibrutinib or decrease those levels, and that can increase side effects, okay? And I know that we're gonna talk about real-world data and treatment discontinuation after me. This is probably more. Okay, these are on clinical trials, but we know that that's probably not the case. There are more treatment discontinuations. Next slide. Now, I don't know how much exposure that you all have to the PI3 kinase inhibitors, which are approved in the relapse setting for CLL. Idelalisib being the first to market, but now we have Duvelisib. There's a whole bunch of other ones as well being looked at. Also, these are called B-cell. They're similar to BTK inhibitors. They're part of the same pathway, but they have a different set of side effect profiles. So people can get an inflammation of the lung, and that could be very serious. We usually stop therapy and give steroids for. People get short of breath. And then there's the GI side effects. And this is what's led to a lot of the discontinuations of this class of agents, because there can be very severe diarrhea that people need to stop therapy for. Because if you're having diarrhea all the time, you can get dehydrated and wind up being hospitalized. So, so these are definitely, again, these medications for folks who are on it, you need to convey the side effects with your team. Very important, because there are ways that we can get people through side effect issues if possible, and if there's not, we have to think about what to do to make your life better. Next slide, please. We're going to pass through, so people always ask me this, so I don't know if this is really relevant as much, depending upon your access to some of these drugs. Now that we have more than one agent available for CLL, there's no doubt that when we talked yesterday, we talked about comorbidities, right? So we talked about age, other medical problems. Physicians do counter, we do think about all these things when we try to choose therapies for our patients. And sometimes we may say, oh, this person has a severe coronary history, they're on this, maybe we'll choose a different class. So this is where some of that factors into decision making. Part of it, though, does depend on access. And as I said, some of these drugs are not available or not, some of them are not, like the PI3 kinase inhibitors are not approved in frontline, they're only in relapse. And so, clearly the BTK inhibitors, first to market, longest usage, and that's why this class has been here to stay. You'll see a lot less usage, but you'll see that there are still patients who definitely benefit from a PI3 kinase inhibitor. So doctors factor in all your comorbidities too. Next slide. Now, Venetoclax, right? So we talked a little bit about this yesterday as the BCL2 inhibitor that got approved in relapse, and now based on the CLL14 data that you guys heard about from others yesterday, this is another new, not so new, but recently approved in frontline therapy as well. So this is a drug that definitely you're going to see a lot more usage of this drug. Now, it's a pill, so like Ibrutinib, it's oral, but it has some other finessing issues, like all of these drugs do. And when patients first start this drug, the doctor certainly has to do a lot more monitoring. If patients have very high white counts or have big, bulky disease, they often have to be admitted to the hospital to start this drug just to monitor people's kidney functions and give hydration and things like that. So there's a monitoring period that occurs when individuals first use this agent for a couple of weeks. And so it's an inconvenience, it's labor intensive, but it's for safety. And so, that could be a little bit of a put-off, and it also depends on the facilities or the whereabouts of where someone's being treated, because this requires getting blood results in real time and being able to manage that. If we're concerned about someone's kidney function, we have to act on it very quickly. It's very easy to do. It's just hydration and some agents that help reduce particular abnormalities in your blood. But sometimes that's not very convenient depending upon where patients are treated. So location will impact some of the therapies, because this may not be able to be given at places where they really can't get blood work done and get those results, very quickly. So their access to that. This drug also tends to reduce people's blood counts, so there's more frequent blood monitoring initially, because they may need some support if they get neutropenic, things like that. There's a little bit more titration that may happen. So a very effective agent. You guys heard about this from others yesterday, but I suspect that, until we get more comfortable using this drug, there may be many doctors who are not quite able to sort of do the monitoring that might be required. That will improve over time. Next slide. Okay. So regardless of the therapies that somebody may get, we talked about, folks, depending upon the therapy, you may have to go to the office more frequently to see your physician or the hospital to see what your blood counts are. You might require transfusional support. They might need more electrolyte monitoring. So particularly with whether it be chemoimmunotherapy, such as FCR, bendamustine, rituximab, those treatments also can cause electrolyte abnormalities. So the doctor may be wanting to see you more frequently or have your blood done more frequently. We always get concerned about increased risk of infection. I'm going to go through that when we talk about immunity. So reporting any signs or symptoms of an infection to your team is also important. And then some of the drugs can cause nausea. Thankfully, there are many good anti-nausea medicines now available compared to 20, 30 years ago, but that doesn't mean, we try to prevent those things. We don't want people being sick. Changes in bowel habits, cognitive changes. We'll talk about that later, about your thinking. Some of the drugs may have some potential for hair loss. Okay, next slide. So let's talk about immunity. So we know that folks with CLL have a compromised immune system. And at diagnosis for patients who are monitored, we're not saying that everybody is their immune system's terrible. I don't want to make that claim. In fact, many individuals are actually very healthy, and their immune system is not so impaired. But folks who start getting treatment, the longer you have the disease, there are other things, and it's not just the CLL cells we focus on. We're talking about sort of the cells in your body that help support the CLL. There are other things that impact people's immunity. Some of them are measurable, like your neutrophil count we can test, but others are not measurable. There are T cells, nerve cells, other things that support your immunity that may contribute to you getting infections. And so that's why it's important to talk to your doctor about infections. And whether or not somebody needs antibiotics or not, that's the point of reaching out to your medical team, because they're going to help guide you about if it's just a virus. Let's monitor, let's do this, so on and so forth. There are some people who get sick all the time. And they're getting antibiotics all the time, or they're getting hospitalized for pneumonias and sinusitis. And so some patients may benefit from gamma globulin. That's an infusion that can boost your immune system, your gamma globulin levels, to try to decrease, doesn't mean they can't get sick either, but try to decrease the frequency of those infections. So it's inconvenient because it's an infusion. Some of them are home, some people can get them at home. And home infusions, some can get it sub-Q, but it's a once-a-month infusion. We have, which I assume you guys have the same thing, currently a shortage of IVIG. So now we're partitioning how do How do we, figure out which patients really need it, because due to the shortage. But anyway, so this is something that some of the patients may be on or may require to see if it helps them decrease their infectious complications. I'm a big proponent of vaccinations. I will not force my patients to get them, but I will certainly counsel to get them. We know that people can get the flu shot and still get the flu. It is not foul-proof, right? So it's only good as the last year's strain. But the point is to try to decrease the incidence of, we're trying to be preventative in CLL. We're trying to protect our folks from getting sick if possible. And if they do get the flu shot and they get the flu, hopefully the severity of their illness is less than if they didn't, right? So I won't force individuals. I think it's important. Obviously, there's a new shingles vaccine, so no live vaccines. And the reason why we used to teach our patients no live vaccines is that theoretically you get a live vaccine, and so whatever that vaccine is, because it's a live virus, you may reactivate whatever that vaccine is. It's a very low risk, but it does happen, so that's why we tell folks, please, no live vaccines. Next slide. What about secondary cancers? So we also know that CLL folks, now remember, cancers, the incidence goes up as we age, so there is that factor, which is true. But we also know that CLL patients have a higher risk of other cancers. And so screening for other cancers is important. And so I always feel like we're a broken record when I go into my clinic, because every clinic, my nurse, my fellow, who's here with me today, my team, we're always asking about other cancers. When did your last derm screening? When did you have your mammo? When did you have your colonoscopy? Right? Because other cancers are curative. We find something, we pick it up, we remove it. So we're aggressive about trying to stay up to date on our cancer screening. Skin being the most common, but certainly there are other cancers as well. Next slide. Transformation. This comes up a lot, and you guys heard a little bit about this yesterday. This is obviously a big problem for us, even though, thankfully, it is not so common. But, common, 5 to 15%, depending upon what you read in the literature. So that's not nothing. And there's no doubt that, it occurs more frequently in patients who have had prior therapies. There's a small cohort of patients, about 10%, who have never had treatment for their disease and can still get Richter's. Those guys are sort of a different category. I'm not going to talk about them because they can do very, very well because it's de novo, and so we can cure a lot of those individuals. But most people with transformation, what we're talking about, are people where their disease is becoming more resistant, and there's a clone that escapes and it changes. Most transformation is to a diffuse large cell lymphoma. Rare, though, it could be some other lymphoma, Hodgkin's, T-cell lymphoma, absolutely, but that's much more rare. And I have to say, we have done abysmally poor at trying to help those individuals. A lot of them are excluded from clinical trials, which is a problem. They're even excluded from some of the lymphoma trials, even though it's Richter's, to a large cell lymphoma, but to be fair, it is different. It's a different disease. And so we're always looking for therapies, and because these individuals are not so common, we need to all partner. The academic centers need to really partner to try to do a trial to really help these individuals. Because most of us give lymphoma-based therapy, and it's terrible. It doesn't really work. So we're always looking to do other things for Richter's. Now, I have to tell you from somebody who's done this a long time, and I may not look that old. Just kidding. But the point is that it has changed. The flavor of Richter's has changed, and hopefully some of us will put that data together. Back in the chemoimmunotherapy era, so people who got FCR, bendamustine, and so on and so forth, and transformed, it was very aggressive very quickly. I'm seeing a different flavor of Richter's in my novel agents in patients who have had some of these oral agents as first-line and second-line therapies. And there are ways to treat them differently and finesse them that I'm not seeing the same aggressiveness. And so the flavor of what we're doing to the disease by these newer treatments is changing some of these other things too. We need to get more data on this, so stay tuned. But there are definitely, I have more Richter's transformation patients who are living with their disease than I did 10 years ago. So I'm just going to say that. Again, not great, this is all anecdotal. We need to put this together, but others, when I talk to my other colleagues here at the IWCL and other meetings, other people are seeing similar things too. So there are different ways to finesse some of our Richter's patients. But that being said, next slide. So again, we try to target the disease, whatever the disease it has transformed to, but we really absolutely need more trials and better ways to treat patients with Richter's. Next slide. Okay, and we're almost done. So other issues. I think, we talk about all the medical stuff, we talk about the drugs, we talk about the side effects. But there's lots of other stuff that go on. It's a chronic illness. And with that comes all the caveats that come with the stuff, besides the medical stuff, psychosocial effects, depression, anxiety, stress. Especially the first year or two after people are diagnosed, that sort of, I'm living with this, how come we're not doing anything? This whole watch and worry, watch and wait, we should change that name. It should be active observation. I like to tell my folks who are being monitored that you may benefit from being monitored because we're coming up with new therapies. Think of it that way. There are different ways to think of this. But it's hard. Psychologically, it's hard. So you need to find counseling, whether it be, if you can't do it with the people around you because you feel like it's too much on them, your partners, your family, it's too much stress, you don't want to burden them, get outside help. Get outside counseling, because it can really impact your life, because you're going to live with this. And the good news is we're living longer with this. So you have to factor that in. There are other physical effects that doctors can't necessarily pinpoint or count and go, is that the medicine? Is that the disease? Sometimes it's not always measurable and we don't know. So it's really, really important to try to figure out ways to adjust to your chronic illnesses. And you have to do it with your other diseases too, high blood pressure, diabetes. You got to learn to incorporate how to figure out how to make your lifestyle better. Stress and weight loss reduction are huge, exercise, natural endorphins, all these things can help, whether it be psychological, physical, things that you can do to better your mental state will absolutely help your physical state. And then there are other things that happen that we don't even talk about. Financial issues, employment issues, loss of work, out of work, disability. Important. So counseling, having a team approach is very important. Many of the physicians have nurse practitioners, what they call, or extended healthcare providers, social workers. Seek counseling. These support groups are wonderful. That's why you're doing this, is to help other patients navigate what's going on with the disease. All this is really, really important. I think we're almost done. I think that's it. Next slide. That's it. So, it's a chronic illness. There are many issues besides the medical. People are always focused on, what is my treatment now? What am I getting? How does this, we're always talking about the medical of right now, but the doctors have to think ahead. What's your next treatment? You might be, you're focused on, I'm about to start Ibrutinib, but I'm always going, okay, and then what about next time and next time? And if I need to think about next time, I have to think ahead for all of you. Most physicians are thinking in the future to keep you going. But what you go through in terms of the chronic issues, really important. Talk to the teams about infection, your immunity. Absolutely, screening is very, very important. And then these other aspects that doctors don't have time to talk to, you need to find somebody to help. Okay?